Okay, well, we've, at the end of the day here, can take an opportunity to reflect on the whole day, but I want to focus primarily on this very broad spectrum that we've already discussed from global climate change and global phenomenon of air pollution down to very molecular mechanisms, disaster consequences and how you surveil those, and then how you use the kinds of epi and environmental health tools to think about interventions and going forward. So it's a broad field, but so we've been given some questions to think about this, and that is, are we appropriately designing research studies? Are we looking at the right scale of things? And I think that's kind of a hard thing to apply because of the range of activities that we're looking at. But do you see areas where the infectious disease environmental health community can take better advantages of the opportunities for growth? In particular, I was struck by the discussion about the very little lack of understanding of the mechanisms, how little progress we've made in recent decades. Is there a way that perhaps looking broader, not looking at the same mechanistic functions that we have relied on in the past, can help move us forward?
So I can start with that. And I really would love to see at least the air pollution field go forward looking at mixtures, because we're not just exposed, even though we can stratify our epidemiological data to look specifically at kind of health effects of one pollutant. We're never exposed to just one. Modeling that is very difficult. And, the EPA certainly has capabilities for rodent studies. Unfortunately, budgets are tight. But they've done some really nice smog studies. And I know Jason Surratt, who's also funded by Health Effects Institute, has done some great modeling looking at kind of the photochemical changes associated with air pollution and how that can affect some of the health effects. But I really think that if we can look at pollution as a mixture and not specifically just focus on one pollutant, we might be able to understand a little bit of the mechanisms better.
I agree. Another way of thinking about mixtures is to think about sources. And as I think I said, I think sources, thinking about air pollution and the sources that generate them is important because it's sources that you control when you want to reduce air pollution and reduce the health effects of air pollution. It's what governments regulate. I think there are areas and particular mixtures or sources that we need to know more about. One of them, and this has come up several times today, are the effects of breathing what people call dust. So there are large parts of the world with very large burdens of disease, in North Africa and the Middle East, sub-Saharan Africa, where if you look at the map that I put up of PM 2.5 levels, there's a huge red band across the top that extends into the Middle East. And when people look at that, and particularly when governments in these places look at that, they go, well, that's dust. And we can't reasonably be expected to do anything about dust. It's dust. It's, God did it. And more to the point, and others in the air pollution community argue that we needn't be all that concerned about it because it's toxicologically unimportant and pretty benign. I think there's certainly been evidence presented here that it's not. So I think that's a mixture from a global disease standpoint. I think it's a mixture, not just for by the way, not just for infectious disease, but clearly for infectious disease that we need to know a lot more about in order to buttress claims that air pollution levels from mixtures with high admixtures of dust in them are not benign.
Two very classical principles in toxicology and environmental health that might help us here when we look at exposures and environmental disease. The first one is the completed exposure pathway, where we really characterize the source, then look at what media are implemented, then look at where the contact point is, and then go through the exposure route and the vulnerable population. So if we are disciplined in doing the same thing for infectious disease and the interaction, I think that will help us. Secondly, the second paradigm is the steps between exposure and disease, because it is for air pollution no longer, and we know now there's enough evidence where air pollution is linked to cardiometabolic disease. And so we're much beyond the lung. So if we think scholarly about what the exposure is, whether it's the mixtures of infectious and pollutants and chemicals and non-chemical stressors. Stress is a pollutant, and then going through and looking at each of the target organs and then see what the overall impact is. Then I think we will make more progress than approaching it in a silo fashion. I mean, this workshop is fantastic to get us out of our silos. We don't have to do more research to figure that out and say more research needs to be done.
Justin, I'd be interested in your view on what modeling can do with that. I mean, a really enormous work scope that you've just laid out, which is characterizing all these compounds and all these exposures, all the health effects, thinking about the molecular biology of infection and disease expression. Can modeling some of these phenomena at larger scale or at smaller scales really make that a more efficient process?
What many of the modelers in the room will know is that models can often expose what we don't know and identify the research gaps that will be necessary because they are wholly dependent on the scales of science that we've heard all the way down from mechanistic study up through to epidemiologic study in order to synthesize information in a coherent way that could then provide those critical estimates we might be looking for, like a burden of disease estimate or the impact of an intervention or the other interests we have in a modeling exercise. And I, as a modeler who sits in an environmental health science department, I often think how we're organizing ourselves scientifically and kind of structurally to better accommodate that process that as a modeler we formalize, but that we've heard many times over today. How are we going to work cross disciplines and together? And the barriers that we've heard about too, like funding interdisciplinary science, funding big team science. A lot of what's been described today in the aspirations that have come from panels before has been big, expensive undertakings that are hard to come by, even with the most enlightened funding program, even with the most interdisciplinary call, that it's just hard to afford the level of scientific and technical integration that many of these problems represent. I also, though, think there is a place to ask ourselves, well, besides funding what we're doing structurally, there probably isn't much that rests on the future of how we organize our academic programs, but maybe this is one of them, that it really matters where you can earn your dissertation and who can sit on your dissertation committee and the way in which you can obtain interdisciplinary training, and therefore how we organize ourselves as a faculty, who we accommodate in an environmental health science department, who our search committees will consider. These are decisions that we're making that we often do so kind of disconnected with these ideas of what is the kind of big science we would like to accomplish. And in fact, we're very conservative and kind of protected in how we fill out the ranks that will train, that will train the next generation of scholars who ideally will kind of pick up on this mantle. So I do think there's some introspection that's necessary to think about whether the way in which we design studies and the limitations therein is in part due to the way we're organizing ourselves intellectually, scientifically, and yes, academically.
I was also struck by Aaron pointing out that all the exposure response studies have been done around the burden of disease for air pollution and these lower respiratory infection curves were largely based on all age cohorts mixed together. And in fact, we know that we have enormous differences based on age, based on health conditions in the backgrounds, and all the nutritional and other elements that affect both infection, disease. So how do we do that given the challenges of mounting these large cohorts?
Well, we didn't do that because we were unaware of those things. We did that because we understood that there was a causal relationship between exposure to air pollution and LRI. We thought it was true for both young children and for the elderly. But there were limitations in the epidemiologic data. We, at the time that we instituted the approach, at the time that we instituted the IER approach for LRI, for technical reasons, it was difficult to fit a stable exposure-response relationship for two of them. I mean, one for children and one for adults. We're working on that now, and then actually the person who's working on it the most is actually in the audience, so you can talk with her. It's Katrine Burkhardt, so I'm turfing this to her, and you can go talk to her about it. But it's a major concern of ours to try and rectify that in the next update, and to have as I said, have age-specific curves. I mean, I think it's a good point to bring up because although I think there are huge limitations to epidemiology that come from exposure assessment and weaknesses in exposure assessment, I think the main source of uncertainty in the global burden of disease estimates for air pollution are their exposure response functions, far and away, without any doubt. And I won't go into the details of it, but it's most certainly true. We happen to be fortunate enough to have complete global coverage at a fairly fine spatial scale, courtesy of NASA, your tax dollars at work, and you know, the Chinese government with a vast array now of PM 2.5 monitors across the country. I mean, so the exposure for PM 2.5 air pollution and increasingly for ozone air pollution is pretty good I think for our purposes. The exposure response function has lots of uncertainty. The question of whether you actually really can integrate relative risk estimates from active smoking, household air pollution, ambient air pollution, secondhand smoke, I think remains a question of a debatable question. It's been a useful thing to do. It's enabled us to make estimates that are important to make, but we continue to look at it critically. So that's the big source of uncertainty. But and one other thing, by the way, Keith Martin, was that? Yeah. Mentioned the Lancet Global Commission on Pollution. And the Lancet Global Commission, if people have looked at that report, and you should, was actually, its business was to look at the global burden of disease and ask the question, is it doing a good job for pollution and the burden of disease? And, other than air pollution, for example. And I think their conclusion was there's lots more that can and should be done. And I think the good news is that's actually starting to happen. And this meeting, for me, really reinforced the importance of that. There's a lot missing, and there's a lot more that can be done. And as I said, I think the good news is that report has been taken, I think, very seriously, and opportunities are being pursued to expand what the GBD is going to include in terms of pollution, not beyond air pollution. And there, frankly, one of the major obstacles is the ability to actually characterize some of these exposures that people have talked about on a global scale, because that's what has to happen. It's not a question of being able to do a study here, a study there. It's a question of being able to get, global estimates for 195 countries. And that's the challenge for expanding those burden estimates to include a much more fulsome environmental burden of disease.
One other frontier of challenge is how do we translate what we're calling the exposome at the individual level to the community level. And so some of us a group of ours are involved in what we call the public health exposome, where we take secondary data, including NASA data, and do projections and modeling. And that has helped to get data and information and associations outside of doing very expensive environmental studies. And so I think the exposome is helping. The notion of lifetime adversity is critical, regardless of what kind of exposure that's going on, rather than taking a snapshot in a person's life.
Sorry, just to add to that, I mean, I know we were talking about age and age-related, how, different susceptibilities might be associated with age. I'm actually happy that the NIH has pushed for the inclusion of both males and females, because I think that sex is something that has been ignored for a long time. And not only when we do these epi studies, do we have to consider sex, but then also premenopausal versus postmenopausal, there's certain hormone components that might kind of explain some of the stratifications that I think would be very helpful.
So one more question, then if there are people from the audience who have others, I'll open it up. But so there's a lot going on in science, both in epi and in the infectious disease space, in the environmental health toxicology space. There's, an explosion of big data that we talked about briefly this morning. Where do you see the opportunities for the greatest sort of scientific advances that will translate into public health? Potentially, or to any of you in the audience, on the panel. Well, I'm leaving that open for you because I'm not convinced that big data actually always is going to be that useful. So as a parameter to consider, but maybe that's not where you think is most important.
Big data is only useful if it's good data. Right? Just big is not necessarily good. What is good is that we do it in a transdisciplinary way, not because we're forced by an RFA, but that we grow it from the start. I'm very glad that we had the focus on a new kind of pipeline of faculty that should begin in middle school. Where we talk about whether it's One Health or looking at environmental health and health from a different perspective. In terms of science, there is a growing and finally a recognition on what we call non-chemical stressors, on the role of stress, whether it's hormonal or otherwise, on disease expression, where people are exposed to the same pathogens or to the same contaminants, and yet we see very different outcomes. To the role of social capitals, the built environment, the social environment, violence, and so all those non-tangible exposures that people sometimes did not want to look at because it's difficult to quantify, yet it is there. And sometimes, or very often, the answers for disease and the answers and the influence of health outcomes ultimately lie in addressing those than in taking away the thing that we know best, whether it's mercury or arsenic. And so looking at it from a holistic perspective requires not only the sciences of toxicology and public health, but the science of social work and the science of mental health to come together to address it, and the science of doing community-engaged research. And so when we begin to value all those disciplines, I think we'll make progress.
So this is probably my own personal stick, but I have had the privilege, since being a faculty member, of interacting with a nutritional lipid biochemist, and he has really kind of helped me understand that nutrition and diet can have a huge impact on health. And from a basic science standpoint, if you think about the rodent chow that we feed our mice or our rats when we're doing our experiments, it's 5% fat. I know I took in more than 5% fat at lunch, so I'm pretty sure what we're feeding these animals, and this might relate some to the microbiome that was talked about earlier, is not really what is in the human population and what we're consuming. And so maybe if we reevaluate, not only diet as, a possible stressor, but then also when we go to model it, are we adequately modeling through diet what, this rodent would be eating if the rodent was a human?
I'll add my own set of wishes to this agenda of where opportunities for impact are. I would say that we heard a bit about opportunities to act. I think it was Molly this afternoon who said where policy is trailing the science, and really we need to drive political will to act on existing knowledge. And as I see it, there are also incredible uncharted territories, just frontiers of knowledge that are either going to be fulfilled, or we're going to be looking back at those as another addition to the list of major environmental transformations that have happened kind of as we were tending to other things. And two examples of that come to my mind. One is that, and to use two examples from California, one is California's Sustainable Groundwater Act, which will take out of active production over the coming years, this is a 2014 passed act and it's about to be implemented, out of production nearly a quarter of California's agricultural land that's currently under productivity. It's going to be a radical land use shift for a state, and it's going to have profound implications. I'm very much interested in dust, in the consequences for the transmission of coccidioides fungi. But what we currently have around the corner from us is an opportunity to be influential for designing or planning where land retirements, agricultural land retirements, are in a state that very much would like its decision-making process to be fueled by the environmental health science. And the other example I would give is on West Nile virus. We're working on the urban epidemiology of West Nile virus, made possible in California through a partnership where incredible big data have been made accessible, including on where vectors and infected vectors are, where dead birds have been verified for West Nile infection, where sentinel chickens are used for ongoing surveillance, and yes, the home address of all Californians who've been infected by West Nile since the disease's emergence. You can put those data together to understand features of the urban environment, including, and importantly, wastewater conveyance, catch basins, even maintenance holes, and their importance for determining where either West Nile infected vectors, birds, or people are, and where those exposures are likely to take place. LA is where we're focusing on this work at present. Water system, especially wastewater system, will be rebuilt in the coming decades from the ground up, and that process will either be informed by a very fine-scale analysis and a very sophisticated understanding of how something like wastewater infrastructure is contributing to the burden of vector-borne infections or not. And so I feel like it's on us in the environmental health science community to kind of vertically integrate ourselves so that we can do that important work of attending to what's right around the corner.
I'm glad you said what you said, because it seems to me that one of the big priorities, it's certainly true for air pollution, it's probably true for other things as well, is to study and understand whether the actions that are taken to reduce air pollution, and whether that's in the United States or whether that's in countries that have very high levels of air pollution like China or India, but the actions, whether those actions actually produce health benefits. It is relatively trivial to estimate what the expected health benefits would be. It is another thing altogether to study whether those actions actually have produced those estimates. And that's actually been a project of the Health Effects Institute since about 2004 with successive RFAs in what it calls its accountability research program, where the accountability refers to the accountability of regulatory programs and other actions to produce what the effects are that they actually use to justify implementing the actions in the first place. This, and there's a whole program of, and there's, a whole bunch of different studies that have, with varying degrees of success, not as successful as we'd hoped, really, to do that. It's a huge challenge to do that because a complex action like the ones that you're talking about can reduce the specific exposure. I mean, you might think the main way you're thinking about them might be, well, do they reduce the specific exposures that are related to disease? But they do a lot of other things. I mean, the U.S. Clean Air Act and all of the things that it has done, it's certainly reduced exposure, and it is demonstrably actually improved health, increased life expectancy. It had a lot of other effects as well. I mean, big, which could have had countervailing effects on that. And it's a real challenge, I think, for the research community to design these accountability studies, but they're absolutely necessary, certainly for air pollution, for other things as well. So that's a huge challenge, I think, for research.
Do you have a question?
Hi, I'm Crystal Ricklick. I'm a postdoc at Hopkins. And since I'm kind of starting my career, I guess something that I would like to look into is the health effects as far as mechanisms of air pollution. And so my sort of practical question for you is, how do we model that in cell culture or in animals that is relevant? Because, we have the knowledge that air pollution here is different than in China, is different than in New York. So you can do a concentrated air pollutant model, but that's going to be different at Rochester versus NYU. They both have programs, but they may not replicate results because they're generating different particulates. So is there a model that's best? Is there a consensus?
That is a loaded question. No, it's a very good question, and I think this is where multi-site studies become very important. HEI is great about funding multi-site studies. So it's basically, I think the Moses study is one of the ones where they did ozone, but it was ozone in I think 5 different locations. So I do think that we need to look at different, I guess, areas/sources, and then almost do kind of, you can harvest particles from different locations, characterize, and then kind of go more towards your bench science with that. So, but we do have great, I was going to say the tools provided by NASA. So at least you can tell when ambient levels are rising in one area versus another. So I think that there's at least tools out there that we can kind of extrapolate. But multi-site, I would say, is kind of the best in my mind.
And similarly, epidemiologically, you need to make sure that your population of concern is comparable. Otherwise, it's apples and oranges.
I'm Ann O'Keefe from Morgan State University. And I would just like to say first that in my long and lucky life, I think this is the largest collection of the smartest people it's ever been my privilege to hear. But the elephant in this room is the federal government shutdown, and I haven't come across any working members of the press, and I don't think you have a press conference scheduled. Those would be opportunities to narrowcast the important message to this administration that, yes, indeed, the federal government has the obligation to protect the health, safety, and welfare of the people here.
I'll be the one that comments on that. It's my own opinion, right? But if anyone watched the KSAC review, the KSAC review did not really bring infection into a lot of the review. Not to say that it was well run. This is KSAC review on PM. But I feel like, yes, we do need to interface more so with the press and possibly policymakers to try to help them understand, the global burden of air pollution as it relates to infectious disease.
And I'll just add that as a federal employee who's not furloughed, as NIH was fortunate enough to have a budget this year, uncharacteristically. But I do know that a number of my colleagues who are working for other agencies on their own time as private citizens are either here or online. So, well, it looks like we are conveniently right down to the end of the meeting of the day, and I'll turn it over to the organizers to, oh, we have a closing remarks.